All right. Well, good morning, everyone. Welcome to the November Fostoria Area Safety Council meeting. It's nice to have a couple names on the screen, and I can at least see one face today. So welcome. Today, our program is Dr. Nappi from Hand and Microsurgery Associates, and he is going to talk to us about critical injury and care of amputated parts. So I just wanted to put that out there. But this morning, I just wanted to give, of course, our normal Dave updates from the BWC. And just as a reminder to everyone else, if you are not receiving the Safety Council newsletter, please let me know, because that has all of the normal updates plus other information we receive that's very pertinent to everyone in the safety related field. So if for some reason you're not receiving those, please let me know so we can get that taken care of. All right. Dave, I'll turn it over to you.
Hi, good morning. Dave Morung, Mansfield Service Office, BWC, your safety representative within the area, and also representative for the Safety Council if you haven't met me already. A few updates through the BWC. The Ohio Safety Congress is coming up. Registration should be coming online here early December. So if you're looking to obtain some additional credit or an experience online virtually, the BWC is hosting that, and that's going to be March 9th and 10th. That's a Wednesday and Thursday of 2022. Right? So if you have any questions pertaining to that, you can contact me or Sarah. You can go through the website. There's additional classes that are remaining for the month of November, virtual classes. OSHA record keeping, that's on November 22nd. It's a half day. Confined space assessment and work, that's November 23rd and 4th. Granted, it's close to the holidays, but if you're needing credit, if it's related to your ISSP program, the public entities, you may want to sit in on that. And then the other one remaining, which is November 30th, it's crisis de-escalation tactics and safe practices workshop. All of them are virtual, and BWC is really working hard to provide that to you. There again, industry specific safety program for the public employees. If you haven't looked at your program and where you're at with your activities, I highly suggest for you to monitor that closely. If you need assistance with that, you can reach out to me. Hopefully maybe get some things closed by the time the deadline, which is December 31st. Now, one thing on the website for public employees, the last day to enroll is in November, but if you're already in the program from the previous year, it automatically enrolls you. And then as for private, it's May. Okay. And so the other thing is, I'd like to make mention, it's just a tidbit. November is Child Safety Awareness Month, and so those who have children and having to work out in wherever you're having to go to, keep in mind that children need to be protected in regards to safety as well. And the last thing I have is everybody have a good holiday, and I have some quick tips, I guess you could say, top 10 that I kind of pulled off that maybe we should probably have a quick overview. So number one, now these aren't listed in any type of priority, but as a general industry, make sure you look at your safety orientation program, right, for all employees, and then also your seasonal work, right? If you're bringing in temps, ladder safety, that's a big one. Lifting techniques, use of real candles, right? Do not use open flame in the workplace, even though some places do, and other related heated sources. Look at your extension cord programs. One of the things that you see during the holidays is to overload your power strips. And also, if you are going to use those, look at your monitoring of your tripping hazards, right? And then monitor and manage your inventory, and then not to overload your work shelves, which then falls into, right, good housekeeping, which some people may have an issue with. They're not like a military format for cleaning. Inspect fire extinguishers, alarms, and detectors. And then follow up on your manufacturing instructions for your holiday decorations and lights. And the last one, drive with due regard. Be safe. So that's all I have for this month.
All right. Thanks, Dave. You've now set the precedence. We want a top 10 every month. Just kidding. Just kidding. Thank you. At this point, I will turn the meeting over to Amy Andrews, who is with Hand and Microsurgery Associates. So welcome, Amy.
Hello, thank you. Dr. Nappi and I are here. We are with Hand and Microsurgery Associates in Columbus, Ohio, up in the Polaris area. So Dr. Nappi is going to discuss work injuries, and I'm going to share the screen here. All right, can you see everything okay? She's muted.
Yes.
Everything looks good.
Okay, all right, I'm going to hand it over to Dr. Nappi. Thank you.
Good morning. We're going to talk about some of the common upper extremity workplace injury problems. We'll talk about trauma. We'll also talk about some of the repetitive motion disorder problems. We'll go through this in that kind of fashion. Some of the most common injuries are going to be lacerations, cuts, scrapes, avulsions, crushes, amputations, puncture wounds, broken bones, sprains, dislocations. Then we'll get into the repetitive motion aspect of things. Year after year, and these are relatively lousy slides, but they show you the incidence of whatever the issue is seems to be very, very consistent year after year after year. As we look at median days away from work, multiple injuries with fractures and fractures seem to lead that, followed shortly thereafter by the infamous carpal tunnel syndrome. And just below that would be tendonitis. A lot of this comes down to ergonomics and body habitus, and you're going to hear me basically say that I think ergonomics has everything to do with almost all of this. When we lose our respect for whatever tool we are working with, that's when we tend to get ourselves injured. As we start out with the repetitive motion disorders, they break into a couple of groups, tendonitis, and then down into entrapment neuropathies. The most common tendonitis in the upper extremity will wind up being Decker veins tendonitis. Probably shortly thereafter will be a tennis elbow type issue. And then significant frequency, especially as we begin to age, will be trigger fingers. All of these can be very much repetitive motion disorder problems. Decker veins was first described back before the turn of the prior century. It's an inflammation of two tendons that control the thumb on the radial styloid. It's right at the base of the thumb. Pain with thumb motion and wrist motions is one of the biggest complaints. A positive Finkelstein's test is nothing more than grasping the thumb and then deviating the wrist a little bit over to the ulnar aspect or little finger side. And a little tenderness we will all have with that move. A positive Finkelstein's test will basically involve the patient usually jumping out of their seat because it hurts so much. First level of treatment for this generally is going to be rest and an appropriate splint. A over-the-counter carpal tunnel splint is not adequate for Decker veins. One has to actually immobilize the thumb in order to try to treat this. That, coupled with a program of non-steroidals, in mild cases will probably remedy over 50% of these. The next step up the line, about the time they will see a hand surgeon, will then, if they failed a couple of weeks of immobilization and rest, we then consider steroid injection. It is only about 99% effective in resolving the acute problem. And a majority of patients with this will not recur unless there is a specific activity that seems to be provoking this. If it is a repetitive motion etiology and we see a recurrence post-steroid injection, we then begin discussing ergonomic evaluation and behavioral modification. Those are extraordinarily important in getting a long-term resolution. Surgery for decurvains is almost never necessary. A majority of these will indeed improve with behavioral modification alone. And some of us would consider surgery to be nothing more than forced behavioral modification. Surgery carries up to a 50% complication rate when done, such things as subluxing or popping tendons afterwards because of what the procedure involves, and especially irritation to the superficial radial nerve that runs right over this operative site. Again, in the area pointed out in red, that is really where at the base of the thumb, we tend to get a profound level of irritation and pain. Lateral epicondylitis or tennis elbow, it begins to peak at ages 40 to 50. It is estimated that 1 to 3% of the general population will have this, and that 7 to 8% of manual laborers will indeed suffer this. And again, peak ages being over 40 seems to significantly increase this. 80 to 90% of lateral epicondylitis or tennis elbows will resolve within a year, regardless of any form of treatment. Treatment options are a multiplicity of different things: injection, PRP, shockwave. Probably most effective is counterforce bracing, a stretching direct massage program with therapy. But most effective is behavioral modification. This generally has a very, very high incidence of occurrence when one tends to place palm down, flex wrist, then grasp and lift. That's one of the motions that we try to avoid and try to relearn appropriate functions with the patient. Surgery, again, from my standpoint, is probably forced behavioral modification. Very frequently, you'll have patients with this undergo an MRI. Why, I've never really figured that part out. MRIs will show quote unquote tears of the common extensor origin. Those tears are roughly about 1/128th of an inch thick. They're normal wear and tear fraying type entities. They're not a physical tear or instability, and they're not reparable type entities. However, when individual hears, "Oh, I have a tear," they immediately think, "I must need something surgical to repair it." Surgery, when done, really goes in and only debrides the area and creates more scar tissue. Therefore, looking at surgical intervention for this should be a very, very last-ditch type of effort. Injections, when done, there are a couple of recent studies that show there's an increased incidence of recurrence after injections. However, those are fairly small groups. The jury is still out. Probably most critical is going to be behavioral modification. Trigger finger. Trigger finger is nothing more than a finger which becomes painful when bending and actually locks in a bent or flexed position. Most commonly occurs in the long finger or ring fingers. It's a very frequent entity in the over 50 population. The more we see patients mature or age, the more frequent the incidence is. Trigger finger may be one of the most common things that is non-traumatic and non-arthritic that we will tend to see in the general population over 50. Underlying diseases, hormonal imbalance can have an increased incidence. Repetitive trauma or repetitive grasp etiologies, especially on small objects, seems to also increase the likelihood of this. First line of treatment usually is a rest non-steroidal program. Oftentimes a night splint, a little $10 over-the-counter Amazon trigger finger splint tends to work extremely effectively for about 50% of people at about 6 to 8 weeks. Should that fail, injection is about 98 to 99% effective in 1 to 2 weeks. Of that group, 80% one-time around injection is curative long-term. Of those who recur, then one has the debate of repeat injection versus considering surgery. Second time around injection patients, 98% get better, 50% of that group forever. So up to 2 injections before considering surgery gets 90% of overall patients better with this entity. We look at it only as something we consider after we've failed conservative treatment. The repetitive activity compression neuropathies, everybody's heard of carpal tunnel syndrome. Cubital tunnel syndrome is the second most common. It is an irritation level around the elbow. And then radial tunnel syndrome, which is frequently confused with tennis elbow. We also have the bad ergonomic positioning or bad posture induced thoracic outlet syndrome that will fit into this group as well. When we look at carpal tunnel, it's the most common compression neuropathy. 3 to 6% of the general population has this. Its incidence increases with age, especially over the age of 40 to 50. Carpal tunnel syndrome has relatively little to do with pain. It is much more a numbness, tingling, loss of dexterity from that numbness type of complaint. In essence, what we have is a compression of the median nerve, which gives us feeling in everything but the little finger near the base of the thumb through a little tunnel called the carpal tunnel that nerve runs. It is a pressure-induced phenomenon. Direct pressure could actually induce carpal tunnel. However, the most common repetitive activity induction is inflammation of the lining of the flexor tendons adjacent to the nerve, which cause swelling in that tight space. Treatment, initially night splinting, plus minus nonsteroidals. Carpal tunnel injection is a relatively effective early on treatment. It is extremely diagnostic, and about 50% of patients that will buy a 6 to 12 month minimum response to that. Surgery considered when conservative treatment fails. Surgery for carpal tunnel syndrome can be done in a multiplicity of ways, from huge open incisions to small open incisions to endoscopic incisions. All of these have their pros and cons based upon the specific individual doing them. It is felt that indeed return to work is quicker after endoscopic releases than with open releases. You avoid a lot of the tender palm with an endoscopic technique. Therefore, the patient's able to return to activity sooner. On average, in some studies, activity return to work as soon as 3 weeks. However, if we have heavy and sustained grip, it will be much longer. The most profound aspect post-surgery for carpal tunnel is a weakness secondary to pain and mechanic change of grip. That grip recovery normally will take 10 to 12 weeks to occur. If one is in a very heavy physical labor activity, return to work at all levels will be much, much longer than someone who is returning to a lighter duty activity. One study showed a 7 to 10 day fewer day off from work in endoscopic releases. A lot of this is very, very debatable, and a lot also depends upon the workers' comp situation with this. John Agee, one of the original inventors of the technique, showed that in his non-workers' comp patients, he had full duty return by 4 weeks' time. But in his workers' comp patients with the same procedure, he was averaging 10 to 11 weeks. Uh, those things are all very, very debatable and very patient oriented and concerning what they go back to. Again, modification of activities permits a much quicker return. Most critically, the question is, well, I had carpal tunnel surgery and I'm still having problems. The most common reason carpal tunnel surgery fails is it was done for the wrong diagnosis. The correct diagnosis has all to do with response to carpal tunnel surgery. In my personal mind, a response to injection is probably the best indicator of whether a patient will improve with surgery. No other aspect of testing or workup ahead of time truly will predict the outcome as well as response to injection. Patients who get improvement transiently from injection have a better than 99% likelihood of improving with surgery. Patients who don't improve with injection have a less than 50% chance of improvement with surgery. These are all things that need to be considered before surgical intervention is basically entertained. The correct diagnosis again matters. EMGs can run a 3 to 15% false positive or false negative rate. They are not a diagnosis. They are merely someone's impression of a response of a nerve to an electric shock. MRI reports are basically the impression of someone who has looked at a bunch of shadows, frequently on a computer screen, but has never examined the patient. They are impressions, they're not diagnoses. Those testings may help support a diagnosis, but in and of themselves do not make the diagnosis. Cubital tunnel syndrome, that'll be numbness of the ring finger, little finger, weakness or clumsiness of the small muscles of the hand, all of those controlled by the ulnar nerve, and frequently associated with medial or inside elbow pain opposite the tennis elbow position. Very, very common with direct pressure to that area of nerve or frequent flexion extension of the elbow. These issues can be treated conservatively on a frequent basis, but they need to be appropriately diagnosed. There is a profound difference between a cubital tunnel compression of the ulnar nerve in the bony groove versus a snapping or subluxing ulnar nerve over the medial epicondyle, which comes about as a result of disruption or sometimes surgical intervention for this problem. Again, overall assessment needs to be performed. Surgery is appropriate if you fail conservative treatment. Most commonly, it is a extension splinting trial for about a month, predominantly at night, but also done to avoid frequent elbow motion and activity. Radial tunnel syndrome is nothing more than irritation of the deep branch of the radial nerves that dives into the supinator muscle. There's a tight little muscular and fascial tunnel. It frequently can be confused with tennis elbow. Tennis elbow will be point tenderness on the bony prominence on the outside of your elbow. Radial tunnel is tenderness basically in the muscle about 1 inch further down the forearm from that tennis elbow point. EMGs are almost always normal in radial tunnel syndrome. So they are not very diagnostic. This is really a clinical diagnostic type entity. Basic treatment, acutely, if it's severe, is rest for about a week, occasionally splinting. Most profoundly, it is a program of therapy involving deep muscular massage and nerve gliding exercises. This will improve over 95% of radial tunnels, and then a behavioral modification program. This is most common in patients who are palm up to palm down, twisting back and forth with force, firing their supinator muscle a lot as one of the most common etiologies of this entity. So behavioral modification, modifying the job activity is extremely important. Ergonomics will basically be very, very important. The aspect of the relaxed position is extremely critical. Ergonomics has a lot to do with thoracic outlet syndrome compression, and that is a distal brachial plexus tightness in the region of the shoulder. It is most significant when the arm is abducted or elevated at the shoulder level. Patient who works on a fixed elevated level line, the 6 foot tall individual does that by extending their arms fully and their shoulders are relatively non-abducted. The 5'4" individual who's slightly shorter will come to an area of about a 50% abduction maneuver to work in that same position. The 5 foot individual will be in probably a 90-degree shoulder position, and that significantly will impact their compression level and predisposition to thoracic outlet. So these types of things are basically done by looking at how one modifies the workstation. The shorter individual needs to indeed be elevated. They're up on a box, up on a step stool, in order to indeed change their shoulder position. Significant attention to the ergonomics is one of the most critical aspects of treating most repetitive motion disorders. We now get into the traumatic aspects of things. Most commonly, again, lacerations. What gets cut can be merely skin, it can be muscle, ligaments, tendons, nerves, arteries, based upon the anatomic position. Looking at a skinned palm, the red structures are the arterial inflow plumbing to the hand and fingers. The white structures that run along with them are the nerves. We have a series of muscles controlled by those nerves. All of the structures are in jeopardy. Looking at the type of injury has a lot to do with what one does. Tendon lacerations, flexor tendons basically bring the fingers into a grasping fist activity. This is the hand of a sous chef who slipped on his knife while chopping vegetables. Got 2 lacerations, little finger, ring finger, with those little white lines you see. And indeed, for him, he was unable to bend those fingers after that injury. Assessed a couple of days post-injury, that was confirmed. And discussion then went on as to whether or not he chose to proceed with tendon repairs. From a workers' comp standpoint, this is a relative nightmare. This is probably a close to 3-month significant rehab program, with taking up to 6 months to reach the maximum outcome. Tendons that are repaired are going to be about 10% as strong as a normal tendon, and therefore quick resumption of any forced load activity will have a very high likelihood of rupturing those repaired tendons. Non-motion of those tendons is very, very prone to those tendons adhering and not gliding in their normal fashion. Therefore, extremely therapy intense. No significant grip activities permitted for up to 6 weeks, and then a progressive increase till full activity comes about at about 10 to 12 weeks time. There we are at about 12 weeks, showing recovery of at least reasonably functional grip, albeit not completely normal, significantly improved for this individual. He was back working one-handed and placed in the splint, and he was back at work, I think, at about 3 to 4 weeks, but was not back completely unrestricted for 12 weeks. Nerves and artery lacerations, when they occur, nerve injuries bring about either diminished sensibility or loss of dexterity due to denervation or inoperation of muscles. Their long-term consequences are susceptibility to re-injury and loss of normal dexterity. Arterial injuries, when you get past the acute hemorrhage or bleeding aspect, basically can also give one long-term cold intolerance and a delay in healing and nerve recovery. All of these things need to be considered when one is considering potential intervention. The results will all be dependent upon, one, the level of trauma, the extent of the trauma, and then the age and the motivation of the individual. The younger the individual, the better the potential functional outcome from nerve repair. Nerve repairs never, and I underline never and say it one more time, never give one a normal outcome. However, in the under 21 age group, nerve repairs can be interpreted as very, very close to normal. From 21 to 40, good functional sensibility and motor recovery occur, but certainly they aren't a normal level. When one gets between about 40 and 60, protective sensibility comes about as a result of nerve recovery. It is not normal, but at least one knows one is touching the area. And nerve repairs beyond the age of 60 give a, at best, very mediocre or very poor outcome. So age of the individual basically has a lot to do with this. Recovering nerves recover at a rate of 1 inch a month from the point of injury. If we're talking of sensation on the tip of the middle finger and our injury is at the base of the thumb, we're talking about a 6-inch distance. That's a 6-month level of recovery for the nerve to regrow. However, they regrow in a random pattern, and what comes back is not a normal interpreted sensibility. They will then require a sensory re-education program that will generally last at least as long as the nerve recovery program did. So a laceration at the wrist level may well be a full year of recovery of sensibility. And if the patient is not motivated for therapy during that time, they'll probably come up with a very mediocre outcome, and they may be best off left alone rather than indeed having a nerve repair that comes out with a worse outcome than they went in with. Examples: laceration at the base of the thumb. If we look on the right, we see those big globs of white tissue with some pink. Those are neuromas from the zone of injury. To repair them, one goes in with a microscope and trims that scar to healthy appearing nerve, advances the nerve ends together, and you can see the little hair-sized sutures next to the blue little retention structure down at the bottom of the picture on the left, which are repaired nerves. Puncture wounds. Let's see, that's a Sawzall blade that came off the Sawzall and has gone about half of its distance into the palm. These basically can cause a lot of destruction. They can cause minimal destruction based on the angle. This individual, very lucky, his angle of entrance missed a majority of the major deep structures. He was merely treated by an extraction of the blade, which was somewhat caught on the deep palmar fascia, but had no significant nerve deficits with this. More critically, puncture wounds are extremely prone to infection. If this is looked at cavalierly and the structure removed, and then we say, oh, we ought to put a couple of stitches in that, we have created a dead space that now can no longer drain, and they have a high incidence of deep infections developing. Appropriate treatment here is merely structure removal, get the blade out of the hand, and then dress the wound openly, permit it to drain and heal by secondary intent. That's about a 10 to 14 day adventure, but significantly diminishes the likelihood of deep space infection. Amputations, avulsions, avulsion meaning ripping off a tissue, not a complete structural bone involved avulsion. They can be fingertips, they can be whole fingers, thumbs, multiple fingers, hand, forearm, lots of variations. The mechanism of trauma, the amount of injury, and the patient commitment to rehab have all to do with what is chosen in the way of next form of treatment. We'll start with fingertips. This is a fingertip amputation. It's the non-dominant index finger of a very close friend of mine who was also a photographer. He closed this in the door of a cabinet he was building and popped the tip off, managed to find that he crushed the amputated piece of tissue. Presented, and we discussed numerous options. Options for this would be one, an open wound technique. In other words, merely dressing the wound open and permitting the wound to heal and contract. He had a small area of exposed bone at the tip, but not a frank bony loss. One could shorten the bone and close the wound primarily with sutures. That will heal the wound quicker. One could put skin grafts on this. One could put a flap on this. One could do fancy major sensate flap reconstructions. After a long, lengthy discussion, since this individual was a surgeon, it was elected to just treat him with an open wound technique. He preferred cross Band-Aids to the original description of using a Vaseline gel over the wound and a little Coban compressive wrap. I prefer the compressive wrap only because it tends to keep the area from swelling and permits healing to occur a little quicker. Best functional outcome actually comes long-term from an open wound technique. Problem, that wound is probably about a 6-week adventure in healing. So one's going to deal with an open wound, and one usually deals with a very apprehensive patient who's sitting there saying, oh my gosh, we got to do something because I've got this big open wound. It takes significant reservation to avoid wanting to jump into an immediate surgical intervention. Next are the sequences. Since this gentleman was also a photographer, he was kind enough to take, indeed, a bunch of photos for this. You see where he is acutely on the left by about 3 weeks' time, day 20 on the right. The wound is contracting, still has a crusted scab, but is making progress at healing. Day 40, as we're just approaching 6 weeks' time, his wound is completely healed, but he's still somewhat hyperkeratotic. That hyperkeratosis continues on for probably another 2 or 3 months' time and needs aggressive local care of just debris mont and moisturization. And here we are at a 2-year follow-up on that same index finger. And as you look at it on the right, yes, I think you can appreciate the tip is just a little bit shorter. However, he's very nicely remodeled. He has advanced normal sensate skin to the entire area of the fingertip. Flaps, primary closures, skin grafts never bring normal sensibility abouts as well as an open wound technique. Probably the best functional long-term outcome, but dealing with the debility of 6 weeks of an open wound. This is what happens when we run out of sawhorses and we kind of realize that the saw is in the wrong position, and these things can occur. Avulsions, this is a engine boring machine rip-off of a forearm with an exposed elbow. In this case, this individual, being in his 50s, was not a good candidate for reattachment, since this thing was totally ripped off and the muscle was totally shredded. In his case, in an attempt to give him relative likelihood of functionality, we scalped the amputated part for a flap of tissue, fat, and nerves, and wrapped it around his stump to give him a healed wound with a functional elbow. Significance: below elbow amputees have about a 95% likelihood of significantly using prosthetics. Above elbow amputees have about a 5, at best 10% likelihood of using upper extremity prosthetics. And therefore, as a general rule, we will do whatever we can to salvage an elbow. or thumb avulsion ripped off in a punch press. No thumb brought in because it cycled, it was totally crushed. Here, we could go with an open wound technique after shortening the bone, but we wind up with essentially no thumb. In this case, we decided we'd take a flap of tissue and some bone off of his big toe, wrap that around that bony stump, and we get something that in essence looks like this when we're done, that somewhat resembles a thumb and has the ability at recovering function and sensibility. Downside, the older the individual, the less apt that one is to consider this type of procedure. Under age 40, functional outcomes are extremely excellent. As we get beyond 40, other alternatives probably should be considered. There we are long term, and I'm extremely self-critical. I think they always look like a damn toe. Even though we've sculpted and tried to shape it closer to a thumb, I don't think they ever totally resemble a thumb, but they functionally work as one for the individual. Or in this case, this is the pulp or all of the soft tissue ripped off the bottom side of a thumb by a punch press. In this case, we merely took a flap of skin with a nerve off the toe, put a little skin graft, leaving the entire toe in place, and put that into position, connected the nerve for sensibility. And there he is showing you recovery of some bendability in a functional appearing thumb. Fractures, dislocations, the next most common thing that tends to occur. The most common adverse outcome of fractures and dislocations is stiffness. All fractures and dislocations have a significant level of soft tissue injury. All of that soft tissue injury heals by making that four-letter word SCAR, or scar. That scar makes things that normally glide stick and adhere and brings about the stiffness. Prolonged splinting of fractures and dislocations always results in stiffness. Early mobilization profoundly reduces the amount of stiffness post-injury. The finger extensor mechanism is extremely prone to adherence. So injuries on the back sides of the fingers especially will be very, very prone to stiff fingers afterwards. Dislocations, bone and joint being popped out of position. On the left is a pure dislocation of the middle joint of the finger. On the right side is a fracture dislocation where the twist element of the injury took off a small zone of bone where one of the ligaments attaches. Most appropriately, we look at this and say that is much more a component of a sprain injury than it is a fracture, because the dislocation tears all of the restraining soft tissue ligaments, which all will heal with scar, and these are even more prone to be long-term stiff than fractures. For dislocations, the appropriate treatment is one reduces the joint to restore the anatomy. We then begin early mobilization that should be begun within a couple of days' time. We need to prevent redislocation, and that sometimes will involve extension or flexion block splinting, but rapid mobilization is probably the hallmark of treatment. Frequently, most of these can be treated in a buddy tape form of fashion. Here we get into fractures. Talking of displacement, the arrow shows you the amount of break in a proximal phalanx at the base of the finger. They're very, very prone to malrotation as well. The fracture on the opposite side is a significant disruption of the ulna and the radius because of the radial fracture. We classify fractures in all sorts of fashions: displaced or non-displaced, stable, unstable, open or closed. Open merely means the fracture actually broke through the skin, is more prone to infection, but that's about its only difference. And then clinical malrotation or malposition. Stable fractures can be treated with early motion. Unstable fractures should be made stable and treated with early motion. Any amount of splinting after any operative intervention, you've created more scar with your operative intervention, and therefore profound or prolonged splinting will bring about even more stiffness. Fractures all will have a soft tissue component. The infamous buddy tape program, but merely using an adjacent digit to help control and splint, will permit motion to be begun very early and significantly reduces the long-term likelihood of stiffness. Here, massive crush injury from a punch press with multiple metacarpal fractures. They are aligned appropriately, pinned into position. Patient is begun at day 2 on motion. Massive swelling requires a lot of additional treatment, but indeed, motion has to be begun as soon as possible. And finally, it's a volar plate avulsion fracture. Is that a fracture or is that a sprain? Well, the joint is appropriately aligned, but to have indeed taken that small chip of bone, one has to have torn and destabilized all of the stabilizing ligaments of that joint. That's a sprain injury. Treating that as a fracture with a splint is extraordinarily prone to a joint with almost no motion. That finger is actually indeed in a very stable position. The joint's aligned. It needs to be treated with early motion by day 2 or 3, preferably. Buddy taping would be probably the most appropriate aspect. That small bony chip, which was the palmar aspect or volar plate ligament attachment, will incorporate into the other area of bone, and it will remodel long-term and not be an issue. For fractures and dislocations, it's therapy, therapy, and therapy. And when you're done with that, a little more therapy. These are minimum 6-month adventures in recovery and endpoint outcomes. That is a normal scar healing type of issue. Scar will be at its maximum production at about 6 weeks' time. It then will remodel and become less of an issue over the next 6 months. So again, therapy, therapy, therapy. Questions from the group?
I'll throw one out there. So when you talked about, I guess I never realized that nerve regrowth was random at times. So is it at every age?
As you look at a repaired nerve, we talk about putting together the little bundles or fascicles. The problem is each one of those has 1,000 or 2,000 nerve fibers in it. And those nerve fibers will begin to grow out. They seek the area of the repaired nerve to go down the tubes. However, if you use the telephone cable analogy, the red cable grows out and grows down the blue, brown, and pink. And the green one goes down the orange, black, and red. And what you get at the end of the nerve recovery is an area that we call cortical disorientation. That is, you got an email and you didn't have a reader for your email. And what you have is a screen full of numbers, letters, and symbols that look like garbage. You can't understand what's going on. And the brain has the same problem. So we then begin sensory re-education, which is a program of reteaching the brain what those new signals mean. And the younger the individual, the better they relearn the sensory re-education. The older the individual, the harder it is to get sensory education to improve. I think old dogs learn new tricks, but very difficult and a lot of beating.
Mm-hmm. Mm-hmm.
Did I hedge that question well enough for you?
You did. Can you speak to sensory re-education a little bit, what that looks like?
It is a simple program of teaching what certain stimuli mean. Nerves will basically control or perceive temperature. They will perceive vibration. They will perceive light touch and then deep touch. So we use different textures. It will be a program of taking the denervated zone and begin stimulating it. It will be something as soft as silk for a light touch stimulation up to something as coarse as a burlap. And indeed, patient will do this with her eyes closed. And you first start seeing what they look like, and then you begin with eyes closed, trying to discriminate. It will then go further. My favorite sensory re-education trick costs 41 cents. It is a penny, a nickel, a dime, and a quarter placed into a pocket. And you put your hand into the pocket and use the denervated zone or sensory recovering zone to discriminate the difference between those coins. The secret, the dime and a quarter, which are different in size, have a rough edge, prevents shaving of the coin. The penny and the nickel have smooth edges, and you learn size and texture discrimination with that. We use the phrase 2-point discrimination. That's part of discerning the rough versus smoothness.
Very interesting. Thank you.
Not just kind of basic hand surgery, unfortunately.
All right. Any other questions out there? I'm looking in the chat too, and I don't see any.
For the guy all the way in the back in the last row, the capital of South Dakota is Pierre.
All right. I do have one comment in our chat. It says, very informative presentation, learned a lot, and thank you so much. And I'm going to echo that. I feel the same. It was extremely interesting. Thank you so much for your thorough presentation.
It's my pleasure. And I'm going to turn you back over to Amy.
Okay. Well, thank you. I learned a tremendous amount. Amy, do you have any closing remarks for us today?
I don't think so. If you want to share my information, if anybody has any questions and wants me to get them any referral information or brochures or anything like that, I'm happy to share that. Feel free to share my cell and email.
Absolutely. Absolutely. Well, again, thank you so much. We greatly appreciate your time and expertise here today.
Thank you for having us.
Oh, absolutely. Absolutely. And everyone on Safety Council, just a reminder that our meeting next month is in December. And our program is Mersha Handrew, who is the Executive Director of the Mental Health Recovery and Services Board. And he is going to talk about substance abuse assistance programs located within Seneca County. So we will send out all that information in our next newsletter, and I will include Amy's contact information as well. So thank you so much for being here. I hope everyone has a wonderful and safe Thanksgiving. Have a great day, everybody.